everyone for coming here today. Hopefully everyone on Zoom can hear me. As mentioned, I'm Mike Freilich. Leanne, you mentioned that we're at St. Mike's right now, which you're right, that's where we first met, but physically we're at Sinai. I'll give that feedback later, but I'm really excited to talk to you today about pragmatic trials and then adaptive trials thereafter. In terms of disclosures and conflicts of interest, so I was a part of a startup company called Proof Diagnostics that developed a point of care diagnostic test using CRISPR for COVID-19, and I'm part of a startup called Signal One, which deploys AI solutions to improve patient care. These are grants that I've received, rejections from many, many more. I haven't received any funding from drug companies. So what are the objectives? Hopefully you'll walk away and be able to answer these questions. What is a pragmatic trial? What do regulatory bodies think about pragmatic trials? What's a regulated trial? Okay, two key concepts. What on earth is an adaptive trial? And if you're still awake by the end, what's the difference between Bayesian and frequentist approaches for statistics? Interrupt at any point in time. So if we rewind back to March 2020, so I started here in 2019, and in March 2020, I looked after a patient a little older than me with COVID on the internal medicine ward. Unfortunately, he deteriorated quite rapidly and required intubation and mechanical ventilation. And that was sort of like the, oh shit moment. And it made me realize that probably what's important from a research standpoint is not diabetes, is not AI, and instead we should probably try to find treatments for COVID-19. And I think the only way you can definitively know if something works is a randomized trial. So this was my my sort of realization at that point in time. It wasn't an original thought, but it certainly motivated me to try to contribute to the literature. And we saw very early on studies being published in pretty prestigious journals. So here's a headline: for the sickest patients, blood thinners may be linked to reduced COVID-19 deaths. And this is all observational research. There's no randomization that's being done. Stuff happens, and then we go in after the fact and study it. We saw more headlines like why prone positioning COVID-19 patients on their stomach can save lives. And then another study suggesting that hydroxychloroquine may boost survival. Again, all non-randomized studies. So if we want to understand why RCTs are so impressive, we need to think about two concepts: external validity and internal validity. Okay, so just, pause in your mind and think, okay, like, what is external validity and what is internal validity? So when we're talking about external validity, it's how well will these results apply to other patients? So often when I'm reading studies in the New England Journal of Medicine on these incredible cancer treatments in patients who are in like their 40s and patients who are almost all white and almost all of high socioeconomic status, I contrast that to the patients I care for on the GIM ward. And I think, you never would have made it into this trial. The patients in this trial look nothing like the patients I'm caring for. So that is external validity. And it all has to do with what are your inclusion and exclusion criteria for your trial. Contrast that with internal validity, and that's how well do the results represent the truth. Okay, how well do the results represent the truth that this drug truly works or doesn't work? And the biggest threats to internal validity are random chance and bias. Okay, so random chance, it's probably intuitive. If you flip a coin, 10 times, and it comes up heads 7 times out of 10, that's just random chance. Now, if you flip that coin 1,000 times, it better come up 500 and 500, otherwise, somebody's hustling you, okay? So if a study is large enough, it should minimize random chance. If it's large enough, it should minimize random chance. But how about bias? So bias is some systematic error leading to an over or underestimate of the association between an exposure and a health outcome. That's full of jargon, so let's break it down, okay? So it's Friday night, and I don't know, you're on Tinder, and you see Jax, okay? And you're like, whoa, Jax, all right. I'm not a big tattoo guy, but I could understand the appeal, okay? So you're thinking, all right, yeah, maybe I'll swipe right. And you show up to the date, and it turns out this is what Jax looks like. He's a goat, all right? He's a goat. So what happened there? You got a biased sample. You didn't get a random selection of photos of Jax. You got selection bias, where he showed you his best possible photo, all right? So that is what bias is. It's some systematic error. Jax is picking his best photos that deviates from what Jax actually looks like. Does that make sense? Okay. In medicine, what we might think about is some study that looks at use of a medication compared to patients who didn't get a medication. And of course, if somebody doesn't get a medication, maybe there's a reason why. Maybe they're about to die. Maybe they can't afford it. And all of those are biases that can affect the association between your exposure and the outcome of interest. So again, bias is some systematic error. And by systematic error, we mean it pushes things in one direction and it ain't from random chance. So one type of bias you can think of is reporting bias. And why are randomized trials so powerful? So just think to yourself for a second, why are randomized trials so freaking powerful? One of the biggest reasons why they're so powerful is that they remove selection bias. The only thing that determines if grandma gets drug A or drug B is a coin flip. That's it, random chance. So if random chance is the only thing that determines who gets what drug, the two patients should look kind of similar because the only thing that determined it was the coin toss. And as a result of that, when you look at the table 1 and you see patients who got drug A versus drug B, their characteristics will look identical. Same age, same sex, same socioeconomic status, etc. Does that make sense so far? Some nods? Okay. And then how do you remove random chance? Well, you just have to have a large enough study. So it's impossible to completely prevent it, but you can minimize it by a really large sample size. So when I see a study of 100 people and it shows that, I don't know, chili peppers like reduce your risk of lung cancer, and it's 100 people, I think, well, maybe it's just a random finding, okay? Whereas if I see a randomized trial where patients got randomized, 1,000 got chili peppers and 1,000 didn't get chili peppers, and you looked at the outcome, and presumably there's no association, but if it showed, hey, chili peppers, reduce your risk of lung cancer, then I think, geez, maybe that's the real deal. This is a large study. I can't blame it on chance alone. So then we can think about why is blinding so powerful? So remember, randomization ensures that at the time the person enters a study, the two groups will look the same. But then how is blinding helpful? Any ideas from the audience in the room? Let's say I'm like a drug manufacturer and I have some new pill and the pill helps with happiness, okay? And you two get the pill, you two don't get the pill. And then I then assign the outcomes. So I ask you, hey, how happy are you? Do you see that there's some subjectivity in that? Absolutely, absolutely. And if I know what you got, and I'm the manufacturer of this miracle vitamin, there is a bias in how I might assess the outcome. So that's why blinding is so helpful, because then the researchers don't know what the patient got, and the researchers shouldn't be able to influence when they adjudicate the outcome. Time-varying confounders, maybe a bit of too much information, so let's skip that. So the big thing with blinding is that it helps to prevent bias when the researchers are assessing the outcome. It also helps to ensure the patient doesn't change their behavior. So with COVID-19, the randomized trials were COVID vaccine versus a needle in the arm. How come? If it wasn't a needle in the arm as a comparator, maybe people who didn't get the vaccine would have changed their behavior. Maybe they would have stayed inside to reduce their risk of ever getting COVID. So hopefully that makes sense. So a quick summary, what have we talked about in the last 10 minutes? Randomization removes selection bias. As a result, the two groups look the same. Blinding removes time-varying confounders, which is a fancy way of saying people changing their behavior over time. And it also helps to remove outcome adjudication bias, so that the researcher isn't biased in how they're assessing the outcome in the patients in their study. Any questions before I keep going? Okay. And again, a large sample size protects against spurious results. So that's why in medicine, in nursing, in anything, when you have a large randomized trial that has been blinded, you're pretty sure that these results are going to give you truth, assuming the study is large enough. So how about pragmatic versus explanatory trials? So pragmatic trials answer the question, does this intervention work under usual conditions? So like when I see my patients on the GIM ward, we might randomize them to 7 days versus 14 days of antibiotics. They're on the GIM ward. Presumably, these are usual conditions, as opposed to explanatory trial where it's under ideal conditions. So Yaz is a heart failure cardiologist, and when you're analyzing a drug for patients who have heart failure, you're going to want to pick the healthiest possible heart failure patients. to make sure that they're able to be robust enough to survive your trial, to take part in trial visits. And in that scenario, you're really answering the question, how well does this drug work under ideal conditions, as opposed to maybe on the general internal medicine ward? But really, it isn't a black and white, it's a spectrum. And in a few minutes, I'll give you examples of pragmatic trials that I was a part of. But the way you think about bucketing a trial as explanatory or pragmatic, part of it is, who selected to participate in the trial and how was that selection? Is it highly restricted? So if you read a study and it's like people had to be under the age of 60, no medical comorbidities, no surgical comorbidities, on no medications, of moderate to high socioeconomic status, no mental health concerns, all of those things make you think this feels much more like explanatory rather than pragmatic. Also, where the study is being done, is it being done on the hospital ward, or is it being done in the outpatient setting where patients are probably much healthier? Other questions are related to follow-up, the primary outcome, and the primary analysis. But the major teaching point here is just to learn that pragmatic trials versus explanatory trials, it's on a spectrum, okay? It's on a spectrum. And often with explanatory trials, they might be placebo-controlled and often blinded, whereas with pragmatic trials, not typically the case. All right, so you want to do your randomized trial. All right, you want to do your randomized trial. There's some patient population. And within that patient population, I don't know how to move this thing down, but this says eligibility criteria are assessed. So at the first stage, you're going to remove patients who don't meet your inclusion or exclusion criteria. Let's see if I can move that. No, not working. Okay, that's all right. Go back to here. And then after that, those individuals get removed. So it's the removal of these individuals that makes you wonder, geez, how well is this going to generalize to the patients I'm caring for? The next step of a randomized trial is you randomize, you flip a coin. Nowadays, we have more fancy statistical software, and then patients get randomized to one of two groups, right? A new nursing bundle of care versus the old nursing bundle of care. And then you follow up patients and you analyze the results. You see who survived, who died, and you perform your analysis at the end. So in a nutshell, this is a randomized trial. And let me walk you through some examples to hopefully bring this to life. So the first one I'll talk about is a COVID-prone trial. So I was the co-PI for this randomized trial. We saw a lot of reports on social media that if you prone position somebody, so like laying on their stomach like this rather than on their back, it would magically improve outcomes. Spoiler alert, it didn't. Another clinical trial that Michelle Scholzberg ran that I was on the steering committee for that looked at the use of blood thinners for patients with COVID. Another one that looked at convalescent plasma for patients with COVID. And then lastly, an adaptive trial. All right, so I'm going to walk you through a few of these trials in high level detail to now give you sort of real life examples. So the COVID-prone trial, so looking backwards in time, in February, you saw these exciting reports on social media and headlines that prone positioning might be helpful. In March is when I looked after my first patient with COVID on the wards in Toronto. And I got together with sort of Amol and Fahad to try to plan a trial. And you want to talk to experts in the field to hear their opinion. So ICU doctor said, you can't prone a patient outside of the ICU. Typically, it's only done in the ICU. A GIM doctor said, we already know proning helps, so what's the point of an RCT? And another GIM doctor said, we know prone positioning doesn't work for COVID. I don't know how they knew these things, but apparently they knew it. But this is perfect. You want a scenario where lots of different individuals disagree. If everyone agrees that something works or something doesn't work, then it might not be the time for a randomized trial. There has to be equipoise. And then ICU doctor is saying, what the heck? Why are you even thinking about doing a trial like this? And then it was a very grassroots approach where I would sort of send an email to colleagues in Toronto saying, hey, we don't have money. We have an idea and a lot of enthusiasm. What do you think about being part of this study? Similarly, reaching out to contacts in the US, messaging people on Twitter. So a very much like by your bootstraps, let's just try to do this and get it done. This paper was published by Kevin Venus and Lavina Munchie, who's an intensivist here, just sort of outlining our understanding of why prone positioning might help. I won't go into the details. We then got a logo made for it, but somebody said, looks like the person is humping the pillow. So we needed something a bit more professional. And with Michelle Scholzberg's help, she found us a graphic designer who made this very slick logo for our clinical trial. And at that point in time, it was all observational data. Some data showed, hey, prone positioning is life-saving. Other data showed it does nothing. And the real problem with observational data, as we talked about, is that these are prone to selection bias. Maybe the people who were prone in these observational studies were the healthiest. They were destined to survive. And maybe the people who weren't prone were palliative. They were about to die. You're not going to prone somebody in their last minutes of life. So in a study like that, you can see the selection bias would suggest, whoa, prone positioning is really helpful. And you'd say, no, selection bias is really powerful. So we received some money. We formed a steering committee. A steering committee is when you have a clinical trial, you're going to make lots of decisions, and it's ideal to have an outside committee to weigh in, to bounce ideas off of them. It's not legally binding, they're volunteers, but a steering committee is so helpful so that when you get to these sticky situations, you don't just rely on what the PIs think, you have experts that help to weigh in. So we had our steering committee meeting in May of 2020, very blurry photo, but is what it is. There's Leanne Jeffs, also part of the study. So the trial in a nutshell, it was unblinded. It was unblinded. How do you blind somebody from being prone or not prone? And we randomized them to 4 times a day prone positioning. The inclusion criteria were very simple. You could prone and you're on oxygen up to 50%. The exclusion criteria, if your BMI was above 40, if you had dementia, or if you had delirium. We were very keen to not exclude previously excluded patient populations. We included pregnant women, we included older adults. And when you're planning a trial, people will give all sorts of suggestions for exclusion criteria. You need to be laser focused and be prepared to politely ignore most of the exclusion criteria. The more exclusion criteria you have, the more work it is for your coordinator to sift through all these. Yeah, go ahead, Nancy.
Like, because COVID was treated so religiously,
yeah,
right? Some got TLC,
yeah,
some got steroids, some got whatever else.
Yeah.
Did that heterogeneity change your potential power?
Yeah, it's a good question. So the trial was so early on that there were no established treatments. It was, I guess, a bit of a wild, wild west of people making things up, essentially. And then what we decided as trialists at Sinai is that every trial that we took on had to allow co-enrollment of other trials. So what that meant is that if somebody got remdesivir in this study, they only got it from random chance from another study. But you're absolutely right. When there are co-interventions that might affect your outcome, in the ideal world, you should probably increase your sample size. But in the setting of chaos, our plan was let's move forward, and it won't be perfect, but let's try to get something done.
And did you ever stratify your randomization based on infections?
I try to only stratify on variables that occur before the time of randomization. As a very good rule, you can only stratify by 1 or 2 variables. And one variable you always want to stratify for a multi-center study is what hospital were they at? Because depending on the population that serves that hospital, you can have wildly different outcomes. So we decided to only stratify on that, and I think maybe it was age. So the variables that you think are strongest, they have the strongest link to affect your outcome are the ones you want to stratify on, and anything that occurs after the time of randomization, you don't want to stratify on. Yeah. So pretty clean inclusion-exclusion criteria. The primary outcome was a composite of death, mechanical ventilation, or worsening respiratory failure. Okay, a composite. So I guess raise your hand, what would be more useful if our trial only looked at death or the combination of all 3? Raise your hand if you think it would be more pure and accurate if we only looked at death. And I'll raise my hand, absolutely. So why didn't we just look at death? Why did we include 3 parts to the composite? Didn't have numbers, yeah. A good trial is a finished trial, okay? So I don't want this trial to outlive my life as a clinician scientist. So when you see a composite outcome, it's to increase statistical power. What do you mean statistical power? What I mean by that is if you want to show that something works or something doesn't work, people have to have the event. So if your outcome is like, what is their risk of living to age 90? Well, guess what? Your study is going to go on for a few decades. So instead, what we do is we have a composite outcome. So we did death, or they were intubated, or worsening respiratory failure. It ain't perfect, but it was pragmatic. So what happened? So we launched the study, and on like day one, we had a randomization, and I was so excited, and then nothing happened. We missed the peak of COVID, and then nothing happened. And we were scratching our head wondering, oh, shoot, is COVID gone? Did we miss our opportunity? A good rule is that as soon as you set up a trial, the eligible patients disappear, okay? And this happened time and time again. Fortunately, we persevered. And sadly, as COVID got worse, our trial was able to recruit more and more patients. We ended up recruiting about 250 patients, and then we stopped for futility. Okay, these were all the sites in total, sites in the GTA, up in Sault Ste. Marie. Sorry, Leanne, I didn't put Espanola on the map. Two sites. Yeah. 2 sites in the US. And what I learned from this trial and the pandemic, all of the nerdy clinician scientists, myself included, work at academic hospitals. All of the patients with COVID, Scarborough, Brampton, areas where there weren't academic centers. So it was a total inversion between where are all the nerdy scientists and where are all the patients. And just from chance alone, as I was texting and cold calling my network, I was very lucky to have people at Humber River and William Osler. Hasina Hussein did a tremendous amount of heavy lifting, Scarborough Health Network. And then these US hospitals, although it's more headaches, at Sinai, we have like 100 internal medicine beds. At Northwestern, they have 1,000 internal medicine beds, right? So you want to go where the patients are. And certainly, Leanne, I know you're thinking about starting a trial yourself. The number one predictor for getting patients at sites, how hungry and enthusiastic is your site lead, and do they have a coordinator? There's an inverse relationship between how much frustration a site causes you and how many patients they recruit. So it was really good learning for me to realize who are the sites that are here to do heavy lifting and who are the sites that just think it's cool to be part of a randomized trial. So anyway, the trial stopped. So we finished in a year. We stopped because of futility. There was no way there was going to be any sign of benefit with prone positioning. So our data safety committee said, this is futile and it's time to stop. And that's what we did. So in the end, we recruited almost 250 patients. This is just looking at oxygenation over time. And even if you're like, what the heck is this? You can see there's no real difference in terms of oxygenation. This was published in BMJ. And of course, this is just one single randomized trial. What's so important is, well, what did the other trials show? So we were very keen to share our data. And then there was a meta-analysis published a few months thereafter. So in total, there was 6 some odd RCTs. This is a forest plot. If you're like, what the heck's a forest plot? Essentially, what you're trying to do here is, okay, you have one randomized trial and you showed this. How about all the other randomized trials? What did they show? And you can see overall, there was no difference in the risk of hard endpoints, like improving risk of respiratory failure, death, etc. A note to myself when I hear about composite outcome is that by composite outcome, we combine a few more outcomes to increase the effect size so that at least we have a significant result. So I personally am not a big fan of composite outcomes. Yeah, fair enough, Ben. I hear what you're saying. In like having done a bunch of trials, it's really hard to do a study with just one single outcome. So in our study, the risk of death was 1%. 1% of the patients died. We totally underestimated that. So if it were the risk of death, I wouldn't be up here with any published data. And there are certain fields in medicine where it's well established. Cardiology, for example, they have a pretty standard composite. But I agree, Ben, ideally, you don't have a composite. So that was the first trial. So let's highlight the teaching points. What made this so pragmatic? Minimal exclusion criteria. Okay, the setting. This is general medical wards, both in academic centers, in the community, flexibility. The point that was already alluded to, we allowed co-intervention. There was no placebo. And the outcome, I would like to think, was patient-centered. Patients care whether they die or not, or they get intubated or not. The outcome wasn't like, how many days were you in hospital? Although patients probably care about that as well. So I hope this highlights a very clearly pragmatic trial. What does the FDA and Health Canada think about pragmatic trials? In a nutshell, they like the idea of them and they want more of them to occur. And I think that's because in industry-funded randomized trials, these explanatory trials, they are so expensive. They can cost hundreds of millions of dollars. Our study received $120,000 and a lot of sweat and hard work. So the FDA, at least if you're curious, is that they're launching a large initiative to get a better understanding of how does the FDA or Health Canada look at these pragmatic trials when they're maybe approving a medication for a new indication. There's a reference document here, but unless you want to fall asleep at night, I wouldn't recommend reading this. So let's talk about a regulated trial. So we started with a pragmatic trial. Let's talk about a regulated trial. So this was a trial of convalescent plasma. What does that mean, Lakshmi? Let's say you recover from COVID, okay? And you say, geez, I might have antibodies in my blood. Maybe you donate your blood, the lab isolates those antibodies, and then Leanne comes into hospital, okay? So maybe the logic is that if Leanne gets some of your antibodies, then maybe she will fight off COVID faster. Does that make sense? Okay, so in the US, what did they do? Very American of them. They did whatever the hell they wanted to, and they just handed out convalescent plasma. No randomized trial. This study was led by Jeannie Callum. Jeannie is a force, and Jeannie said, I will not allow any convalescent plasma given anywhere in Ontario unless it's through a randomized trial. And she was very smart to do so. So these were patients hospitalized on the ward, 1,000 patients in total. They got randomized to convalescent plasma versus standard of care, and another ugly composite outcome, but nicer than our composite outcome of intubation or death. A pretty clean outcome. So I remember caring for a patient, this little old Italian lady who I really liked, and we randomized her, and she got randomized to not get convalescent plasma. I felt terrible, all right? And unfortunately, she went into respiratory failure and went to the ICU. So what do you guys think I was thinking at that point in time? What was I thinking at that point in time? I wish she got convalescent plasma. I wish she got it. God, I felt terrible. But that's the whole point of randomized trials, okay? The whole point of randomized trials is I really like that patient. So maybe if I really like her, I would say, hey, let me just get you some convalescent plasma anyway. That's selection bias. You're not determining that based on a coin toss. You're determining that based on my own biases, okay? So what did we actually find in this study? Convalescent plasma didn't work. It actually worsened outcomes. It worsened outcomes. Meanwhile, in the US, they're convinced it works based on observational data, and I think they're delusional, okay? So this was published a couple of years ago now, and this was also stopped. This trial was stopped early because it showed no clear benefit, and if anything, potentially an increased risk of this composite of intubation or death. Some people look at confidence intervals and think, I don't know what that is. Other people look at confidence intervals and think, whoa, I mean, well, it didn't cross one, so we should just ignore that. That's incorrect. Maybe another point in time, I'll give you a crash course on how to appropriately interpret 95% confidence intervals. So another regulated trial. So I guess, why was this Health Canada regulated? We were giving convalescent plasma. This was a new substance. So Health Canada would not say, oh yeah, this isn't regulated, just do what the hell you want. No, this is a brand new treatment. So if it's Health Canada regulated, essentially it requires more monitoring, more paperwork, more money, more research coordinators. The next randomized trial, these were for patients hospitalized on the ward with COVID, randomized to full dose blood thinners or prophylactic blood thinners. Again, another composite outcome. And somebody remind me, just so I can tell that people are awake and alive, why do we use composite outcomes? Yeah, exactly, right? So from a composite outcome, then there's more ways people can get the outcome. You increase your power and hopefully a smaller sample size. Precisely, that's right. And as Ben alluded to, Composite outcomes are kind of ugly because it'd be ideal if you just had one single outcome. Because then when you explain it to the patient, you say, hey, here's this drug. It reduces your risk of death. Instead of saying, hey, here's this drug. It reduces your risk of death or respiratory failure or mechanical intubation or needing to leave hospital. So you can see how it's much cleaner if you have one single outcome. So in this study, it showed a reduction in the risk of mortality, mechanical ventilation, and ICU admission. Yes, the p-value was above 0.05. I can chat in the question and answer period why p-values were never designed to say, does this work or does it not work? This was subsequently published in the BMJ, and as mentioned, Michelle Scholzberg was the lead author. So how is that different than a pragmatic trial? So how are those two different than a pragmatic trial? So paperwork, big difference. All right, pragmatic trials, think less paperwork. Monitoring. We had to do much more monitoring for the trial of heparin. What do you mean monitoring? I mean, like, look at these gray hairs, okay? What they would require us to do, we had to take the temperature of the heparin before it left the pharmacy. We had to keep a temperature probe all the way to the ward. We then had to make sure it stayed at the same temperature as the nurse then hung the drug and gave the drug. So way more steps for monitoring, some of which I think is unnecessary and probably overkill. You also need to have typically individual sites where their whole job is just to monitor your trial. And then speed. Pragmatic trials are usually faster. So what trials will be regulated? So if it's a new molecule, so like, hey, convalescent plasma, that's a new molecule. Therefore, it should be regulated. If it's an old molecule, heparin, but a new indication, COVID. And we met with Health Canada and we said, please, 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 please don't make this a regulated trial. We give heparin all the time. And Health Canada is very risk averse. So they said, no, it needs to be regulated, which equals more paperwork, more money, and harder to get things done. So, you know, if Leanne were to lead a trial on how we should deploy bundles of care for nursing, that's a pragmatic trial. That ain't a drug. Yeah, question, go ahead.
Mike, we're starting to see a lot of QI and RCTs kind of coming together. There's a study in the cardiology world looking at AI using AI for coronary artery disease RCTs, and then sending that data to patients as a QI, and then looking at the outcome stats.
Yeah.
And through this whole process, there's no patient consent because this is standard of care.
Yeah.
So do you see pragmatic trials becoming something along the spectrum of QI as well?
Yeah, I think there's no reason why it can't be embedded into QI. Absolutely. I work with some researchers in Denmark where it's like a utopia. And there they have these pragmatic trials which are just embedded to care. So Leanne, you go to see your family doctor this afternoon. Before you see your family doctor, you get an email. It says, hey, Leanne, you're due for a flu shot. We're going to randomize you to high dose or low dose. How does that sound? You say, yeah, I don't care. Sure. You see your doctor, they jab you in the arm, and that's it. And then they follow Leanne's outcomes, never by calling her, never by sending her an email. They just see when she ends up, hopefully not, being hospitalized to see if she had the outcome. So I think we're seeing more and more pragmatic trials just embedded beautifully into care. And I think those types of trials are what will truly increase inclusivity for patient populations. But yeah, I wouldn't be surprised. Like, I like QI, I do, but if anything isn't randomized, how do you know for sure your QI intervention actually helped? Yeah. Okay, so we talked about a lot. We talked about randomized trials and why they're amazing because they remove selection bias. We talked about pragmatic trials, less paperwork. We talked about regulated trials, more paperwork, and regulated trials for new drugs or old drugs for new reasons. Now we're going to talk about adaptive trials. Okay, so a whirlwind tour. Any questions? Lakshmi, any questions? No? Questions? Concerns? No? Okay, so let's talk about adaptive trials. All right, deep breath. So this is how the FDA defines it. It's a clinical trial that allows for prospective modifications as you go. So currently what happens for most trials that are not adaptive, you have a single study plan and you got to do it. And if halfway through you think, oh geez, we should have actually used a higher dose or a lower dose or added something else in, you got to start all over again and write a brand new trial protocol. That ain't fun, okay? So the idea of adaptive trials is that as you go, you can review, make changes, adapt, and continue. The purists think this isn't pure, and I guess they're right. Whereas in a traditional randomized trial, and all the trials I told you about, we said, hey, we're going to study prone positioning. Boom, let's go. Hey, we're going to study blood thinners. Boom, let's go. But in none of those trials did we say, well, maybe if blood thinners don't work, we should add a new drug or subtract a drug. So what are the aspects of the trials? So you can have adaptive randomization. What does that mean? This is information overload. Let's say you're doing a trial, and as you go along the trial, you realize, whoa, holy crow, this new drug appears to be really helping people. You can change the randomization so that it isn't 1-to-1, but like 2-to-1, so that the next person is more likely to get this drug that appears to work. That's one way a trial can be adaptive. The other way a trial can be adaptive is multi-arm studies. So maybe at first you want to know blood thinners versus no blood thinners. And then maybe as you go, you want to do something new, like aspirin, SGLT2, I don't know, but you're adding new arms. If this is confusing, then you're in good company. But I'll give some nice examples which show a real life adaptive trial. So this was a solidarity trial, or CATCO. So the World Health Organization made a pitch. Rather than individual researchers all studying their own pet project for a certain drug, let's all come together. Let's all come together and have a global trial. And in Canada, Rob Fowler and others were already planning their own trial, but Rob Fowler, being the guy he is, the great guy he is, said, you know what, this isn't about me. Let's join the World Health Organization in their trial. Sure, we won't have as much control, but let's go in this together. So that was the approach. What do you think the Americans said? What do you think, Lakshmi? You think the Americans like the idea of this? No, exactly, right? It's America. We do what we want, okay? So there were almost no American sites in this study. I'm very proud that there were many Canadian sites. I was a lead here at Sinai, and it was over 500 hospitals worldwide: India, Brazil, Saudi Arabia, Canada, you name it. So we wanted to see, does remdesivir, so it was a multi-arm study. Patients got randomized to remdesivir, hydroxychloroquine, which is Donald Trump's favorite medication, interferon, or lopinavir. But as an adaptive trial, what we said was, if after we randomize some patients and we realize something certainly doesn't work, we're going to drop it and add a new drug that might potentially work. Does that make sense? Sort of ish. Okay. So, and the outcome was mortality. Okay. So Ben will like this one: mortality, dead or alive. That's it. So what we found after the first 1,200 patients were randomized was that remdesivir might help. Hydroxychloroquine did not help and was probably killing grandma. Interferon did not work and was probably killing grandma. And lopinavir, probably no difference. So it's an adaptive trial. So what we did was we made changes. We dropped those 3 drugs and we continued with remdesivir for reasons that it appeared there was going to be a potential benefit. And we added new drugs thereafter. So this was the next study that looked at just remdesivir alone. This was one of the definitive trials that showed remdesivir is helpful for patients hospitalized with COVID and on oxygen, and which is why it is standard of care worldwide. So they added some more drugs thereafter. So they added artesunate, imatinib, infliximab, higher dose of dexamethasone, and other stuff. And this is the idea of an adaptive trial. If you find something is hurting people, drop it. If you find something works, drop it, and this should become standard of care, and then add new drugs. So what this allows you to do is not start a brand new protocol, a brand new application, and ideally this is supposed to be more efficient. Kind of makes sense? Kind of. Okay, no one's sleeping. That's a good sign. So what are some drawbacks of adaptive trials? You know, Yaz, what you were alluding to before, there's a real risk of multiple testing. So when the study was designed, we had no power calculations. We said, we're going to go out there and randomize as many patients as humanly possible. So in total, there was like 17,000 patients randomized globally, but we never had any statistical testing because how do you do statistical testing? How do you plan for a study for a pandemic you've never seen before? But that can be criticized. There's a risk of phishing as a result. The biggest thing for the research coordinators in the room, so much paperwork, okay? So I've promised my lab we will never do another adaptive design. I don't have a good memory. We're doing another adaptive design trial right now. Very expensive. All right, we're almost done.
It's expensive. When you were asking the question earlier, I was thinking that might the adaptive
Yeah.
Adaptation, but then so it's very tricky, right?
Yeah. And in general, if you can never do an adaptive trial, your research coordinators will like you more. I've never seen so much paperwork, and it would be like, hey, we have a new adaptation, and we did the paperwork, and then a month later, they're like, oh, just kidding, there's actually another new adaptation. I was like, you guys are killing me. So I lost my lab, like we had no plan. It was just boom, do it. So my lab went into the red like $100,000 from these trials because they were so much work. Fortunately, the foundation, to their credit, backstopped my lab, but yeah, they're a ton of work. Okay, so what have we learned? Okay, a pragmatic trial, does this work in routine care? Pragmatic, less paperwork. And we also learned that the difference between pragmatic and explanatory, it's on a continuum. It's not black or white. What we've talked a lot about is how pragmatic trials predominantly differ in this eligibility criteria of who's being assessed for it. That's predominantly where the pragmatic trial versus explanatory trial comes into play, is the inclusion and exclusion criteria. We talked about a regulated trial, and that's needed for a new molecule, like a new drug, or an old drug for a new indication. These are a lot more paperwork, more monitoring, more money. And then adaptive trial, man, it sounds like a cool idea. It allows for changes over time, but in real life, it's an incredible amount of work. So what we didn't talk about is the analysis stage. That's, I think, TMI, and we're probably out of time. So I'm not going to go into the difference between frequentist versus Bayesian statistics. I'm going to actually just pause here and see if people have any questions, and let's take a look at the chat. Yeah, agreed. Ben, personally, I'm not in a hate-love relationship with composite outcome, and we're even reporting in our latest publication, but we're also reporting elements. I really adore and appreciate what your studies are, especially ones. Thank you. I appreciate that. Yeah. Any questions that you have? No, it's a quiet group. That's okay. It's still morning. So then why don't we just go through a bit more pain so you at least learn what frequentist versus Bayesian means. The frequentist hypothesis really perseverates over p-values. You're trying to disprove a hypothesis. Because remember, it's always easier to disprove something than it is to prove something in life. So we always talked about rejecting some null hypothesis. I love candy. My lab knows this. Okay, so let's understand this very simply. So the idea behind the frequentist approach is that you have a probability. Okay, so Lakshmi, I'm going to close my eyes. Okay, and what's a probability? I'm going to pick my favorite jub, which is a red jub. Well, you can calculate that, right? A probability is just the ideal event divided by all possible events. So a red jub divided by all jubs, all probabilities are bounded from 0 to 1. So the probability is 20%. I don't like that. I don't like that probability. Okay, I'm not going to put my hand in that bag. I don't want that black jub. Don't want the yellow one. Don't want the green one. Okay, but this is what probability is: the ideal event divided by all possible events. So a p-value is just a probability spanning from 0 to 1, and it's a probability of finding the observed or more observed result when the null hypothesis is true. TMI, maybe Leanne, I'll send around. I have a 5-minute video on what a p-value is and what it is not. That's probably higher yield than me walking through all of this. But let me just contrast that with the Bayesian approach. So with frequentist approach, you have a p-value, you love the p-value, you pet the p-value, and if it's less than 0.05, you say, hey, this works. And if it's above 0.05, you say, hey, this doesn't work. The Bayesian approach is much more different. The Bayesian approach wants to say, what is the probability that this might work? I'm going to bring it to life. There's interesting here backstory on the history of Bayesian statistics. This is Lord Bayes himself. It turns out he didn't really do all that much, but he had great marketing and he named it after himself. And it wasn't until future researchers used these theories to predict where planets would be based on prior information. But really, when you think of Bayesian statistics, you can think of the game Battleship. So raise your hand if you played the game Battleship before. Yeah, perfect. Okay, so you're playing Battleship, right? And you're gonna say, hey, B2. And then Leanne says, nope. So you're using that information to update your probability. So you say, okay, all right. I guess Leanne doesn't have a boat in the B2 area, so I'm gonna go elsewhere. That is Bayesian. You take in information and you update what you do next. And I think a real life example might help. Raise your hand if you bike to work each day. No, me neither. I did it a bit in the fall, but let's say you took the bike to work or you took a train to work, okay? And each day you recorded how much time it took. So you plotted out how long it took if you took the train and how long it took if you took the bike, and then you plotted that information out. And essentially what you're gonna ask yourself is, after we analyze all the data, what does it look like? So after you analyze all of the data, what it looks like is that taking the bike is faster, and here's the distribution. So in a frequentist approach, you'd say, hey, biking is faster, the p-value is blank. In a Bayesian approach, you would report, here's the probability that biking might be faster. There are some nice real life examples of studies that were analyzed using just a frequentist approach, where people's brains stopped working because the p-value wasn't less than 0.05, and they said, hey, this actually doesn't work. And then you reanalyze it using Bayesian statistics and you realize, whoops, we were wrong. So this is something called ECMO, which has become the standard of care for people on life support. In the context of COVID-19, all the studies I talked about were frequentist, all frequentist. None of them were Bayesian. There were a couple studies that did do a Bayesian approach. They're published here. And again, the way they report their results are, what is the probability this works? Rather than the p-value is this, therefore this works or it doesn't work. They're instead giving you, what is the probability that something works or something hurts? So what were 6 teaching points that maybe you'll walk away from today? That pragmatic and explanatory trials are not two mutually exclusive groups, okay? It's like on a spectrum, okay? So you can have pragmatic aspects and you can have non-pragmatic aspects. It's all on a spectrum. You learned, I hope, that regulated trials are more often explanatory and required for new drugs or old drugs with new indications. I hope you learned that adaptive trials are a lot of pain, but sound kind of cool, and you can add things and subtract things as you go. It's in the name, so hopefully that's easy to remember. Most trials use a frequentist approach where you have some p-value. Bayesian statistics are confusing, okay? So hopefully that's what you learned today. I'm always happy to chat more. We got to get out of here in a few minutes, so I'll wrap up now, and thanks so much for your attention and time.
Thanks, Mike. Are there any questions from here? If you ever want to know, are you involved in trials?